Welcome back to another episode of the Braun Performance and Rehab Podcast, powered by ISOFIT, Oro Muscles, and Firefly Recovery. ISOFIT is my go-to for all things isometric strength training. For more on ISOFIT, be sure to check out isofit.com. Oro Muscles revolutionizes rehabilitation with real-time actionable insights into muscle activity with live biofeedback and instant analysis, which has made a huge impact in my work with athletes. For more on Oro, be sure to check out oromuscles.com. Episodes like this are made possible by Firefly, the official recovery provider of the Braun Performance and Rehab Podcast. For more on Firefly, be sure to check out recoveryfirefly.com. Joining me today is Mitch Toda. I've had the pleasure of knowing Mitch for several months. I've been highly impressed by him. He's a phenomenal individual and a great clinician. I love the work that he's been doing. Mitch and I dive into acute injury assessment and management in the podcast today. This is an area where I personally don't have a ton of firsthand experience, and I learned so much from Mitch in today's episode, diving into his processes and frameworks, if you will. If you're working with athletes or do any acute injury coverage, this is a great episode for you. Enjoy. Mitch, welcome to the podcast. I'm super excited to work with you today, man. For people who maybe aren't familiar with you or haven't seen any of the amazing work you've done in the soccer space, would you mind filling them in a little bit about who you are and all that you've got going on?
Yeah, thanks, Dan. Thanks for having me. I'm excited to be on. I am an athletic trainer by education and by practice. I am currently just started a new role with a women's professional soccer side in the NWSL, North Carolina Courage, as the head athletic trainer. And prior to that, 5 of the last 7 years, I was working in MLS, Major League Soccer systems, with Minnesota back in 18 and 19, and then Orlando for the past 3 seasons. Mixed in there, I had a little bit of orthopedic clinic coverage, high school coverage, things of that nature during the COVID years. And then prior to jumping to the MLS, I was working a dozen years or so in the collegiate Division I settings at various schools. So I played soccer in college for 3 years, which is a kind of a loose term because I didn't play much in games. I was more so on the team, right, for 3 seasons, which was honestly, it was a blessing because I was able to play the sport that I really enjoyed, and I was also able to get my athletic training degree when it was a bachelor's. So, I don't think I would be where I am right now without having that type of experience, and I'm really grateful that I get to really do a full deep dive into the soccer world, especially at the highest level that that North America offers at the moment. So yeah, hopefully that summarizes it a little bit.
Yeah, 100%, man. I mean, it's great that you've got that history of playing soccer yourself, but also the history of, being involved in soccer from that sports medicine side of things for a variety of different years and a variety of different settings too, professional men's, professional women's, collegiate settings, and so on that way. So you've kind of gotten to see a lot of different angles and a lot of different things in relation to the sport of soccer. And I feel like every time I'm talking with someone about soccer, that acute injury conversation comes up that way, in particular of the lower extremity, hips, knees, ankles. It seems like soccer is really prone to lower extremity injuries that way acutely, in game. And I think, almost every time I pull a soccer game up on the TV, I'm seeing someone go down with something. Maybe it's not the most serious thing in the world. Maybe they're back the next game, but this seems like a real common occurrence and common problem that way. And I'm interested to hear your thoughts. Why do you think lower extremity injuries are just so common in the sport of soccer that way? And are there any ones that you see in particular standing out amongst others, whether that be ACL or, soft tissue muscular stuff or that sort of thing?
Yeah, well, first of all, Dan, that's a very loaded question. Yeah, there's
Always is, right?
um, there's obviously ACLs are quite prevalent, especially in the women's game. There seems to be a higher incidence rate versus the men's for various reasons. but ankle sprains and ankle injuries, they are pretty common in both. Quad and hamstring injuries are at probably the highest incidence rates now than ever has been. Hip and groin injuries are pretty prevalent as well. A lot of, based on my experience, particular soft tissue injuries, they tend to come, in my opinion, from a lot of muscular imbalances, and movement dysfunctions that are caused by hyperactive or yeah, hyperactivity and hypoactivity of different muscles that work together, synergize to create functional movement. And especially when you add in, the dynamic and explosive nature of a lot of the soccer actions, right? Whether it's sprinting or jumping or kicking. Kicking is a very, I would say, pretty unique to the soccer world. Of course, there are other sports that do that, but not so much as soccer players, right? And quad injuries are very frequently seen in soccer players, and rightfully so. They're used in running, jumping, cutting, and particularly in kicking, especially going into full wind up, as I call it, really stretching that fascial system of going into hip extension, knee flexion, while also, rotating away with the upper body and trunk. And that maximal stretch is an area that really doesn't get trained very well, right, in any other spaces. And so one of the things that I emphasize, just not to change subject too much, but one of the areas that I like to emphasize in what I would call pre-training activation is trying to become long and strong. And that's something that I utilize in the rehab space as well. So really putting someone in a maximal tension position, maximal stretch position, and then being able to produce force and provide resistance in that range, which is typically the most vulnerable for soft tissue injuries, for muscle injuries. So a lot of isometrics actually in that type of position is kind of my go-to at this point. So whether it is a wind up in a kick position or a wind up in a hamstring, right? Like a forward lean and maximal hip flexion and knee extension type of position, getting into that type of position and then pulling using the targeted muscles. I think those are ways to really build robustness in muscles and tendons. Again, I say loaded question earlier, Dan, because not all muscle injuries are created equal, right?
Right.
And so you have more superficial myofascial injuries versus musculotendinous versus intratendinous injuries, and that gets into a whole different realm of how do you approach those differently to provide the appropriate load to really target those tissues, and that's really important to know in creating a structured rehab plan that's really going to be effective. So having an accurate diagnosis is really important right from the get-go. And particularly when you get into, let's say, knee injuries, right? You have four major ligaments that are stabilizing there. It's really important to know which structures are injured and how severe those injuries are, right? To be able to provide a good rehab plan or even a treatment plan, right? Is it surgical or non-surgical? And I think, again, just going back to the original question is, why are they so prevalent? Well, I don't know how well we do to prepare players, right, for the demands of the sport and to protect the body parts that are most vulnerable. So there's definitely an area for improvement there, I think, across the board.
Yeah, 100%. You brought up so many great points there, Mitch. And just to take your point on diagnostics for a quick second there, that is the difference, in my opinion, between working with a generalist and a specialist in the space that way. I think in sports medicine, it's very, very essential for us to get to that accurate diagnosis and understand what was injured, where was it injured. It's not just a quad strain. I want to know what muscle and I want to know what portion of the quad, to your point about, was it superficial? Was it musculotendinous junction? Was it more like the tendon itself that way, distal or proximal? Like, the ICD-10 diagnoses, and I mean, I'm guilty of it myself. Like, until I get an actual MRI confirmed diagnosis, I'll call things, a quad strain, or I'll call it a, ACL or a potential internal derangement, if you will, of the knee. But we really need to get to the accurate diagnosis of what is actually going on here, because the more we know, the more targeted we can be with our interventions. And obviously, the quicker someone's able to get back following that injury, because, time is money, as they say. And if you've got someone who's out 8 to 10 weeks for a grade 1 quad strain, then you're clearly inefficient in your rehab process, I would say that way.
Yeah, for sure. And that grading system is another one that's interesting, right? Is how granular are the details of the grading system? The one that I've utilized most, or really all of them at this point, over the past 3 or 4 years, is the British Athletic Muscle Injury Classification System, and it provides not only the number grade, so the size of the tear, both length and the across, how much percentage of the width of the muscle tissue is injured, but also the location of the injury, right? Again, kind of going back into what I was saying earlier, the ABC subcategories. So A would be myofascial, most superficial. They tend to take less time to recover from, and they respond to treatment really, really well. But sometimes they feel like something exploded in their muscle early on. And so there's a lot of, panic initially, but then it recovers pretty quickly. Grade two, sorry, not grade two, the B and C subcategories then get more deeper into the tissue. So the B being myotendinous junction, and so you have a little bit of muscle, but you also have some tendon involvement in the muscle injury, and then finally the intratendinous, which is purely in the tendon, and those are really really tough to rehab, and because they're extremely stubborn, they don't respond very well to initial treatment, and and it just takes time, and the re-injury rates are higher. So yeah, so you look at those types of granular details that are required to provide a really good structured rehab program that's targeted for the tissue that's injured. And that is a challenge.
Yeah, 100%, 100%, man. And I mean, to that point as well, I guess I kind of wonder, like, obviously that soft tissue injury component is a huge black box. And, to your point from before, there's a lot of loaded questions in this space that way. And there's a lot we know, there's a lot we don't know. I think we can all agree, to your point, that tendons are super dumb. And they just like, I don't know, tendons are irritating. They're important, but when they get hurt, man, they are the dumbest things. When it comes to those soft tissue injuries, or, low grade ankle sprains, like there are certain times where I see athletes, obviously they're still down bad, but they go back in and actually play through some of it. Not always, but
Mhm,
I've seen it done before, where athletes kind of get like patched up, so to speak, if you will,
mhm.
give them the tape job, WD-40, duct tape, hold them together for 10 minutes, go out there and, win us the game kind of thing that way. But I think, at least from my eyes, being a little bit more on the long-term rehab side of things, as opposed to the acute side as much, I feel like there's always like a risk reward conversation that must take place with stuff like that, where it's like, hey, it doesn't seem too bad right now, but if you go back out there, you could make this significantly worse. Or to your point about muscle imbalances contributing to, different soft tissue injuries that way, I would also be willing to bet that those can contribute to other injuries in other areas as well. If we injure a hamstring on one side and we start compensating in some crazy way, it becomes a question of what else could we injure instead of just that
Mhm.
hamstring. So I'd imagine that risk reward ratio conversation, if you will, about returning someone into the game after an injury is always a ever evolving process, if you will.
Yeah, it's a great point, and let's say, take a lateral ankle sprain, for example. That's something that we commonly see in soccer. It's probably the most common, joint injury that we see, especially on the men's side. But that risk reward is really based on how functional are you, right away. Oftentimes the range of motion diminishes rather quickly. One of the first things that we check is there big signs and symptoms that might indicate that there's a possible bony injury, and so a distal fibular fracture or a an avulsion fracture. Those are not probably not as severe. I would say distal fibular fractures are for sure way more severe, but it when you rule that out and it seems like the ankle joint is good in terms of a bony injury, the next thing you want to check is stability, right? And so you do a couple tests, check the laxity and the pain level, and you want to go through the range of motion and strength testing to make sure that they can activate all the muscles. Whether it's painful or not, I think it's one thing. I think the my question really initially is, how functional are you, right? You can be in pain, but you can be fully functional. And in those cases, that's really where the question lies of, okay, well, are you able to participate fully, even though you might have a little bit of pain, without having those compensations like you speak of, right? So when you have an ankle injury and you're able to fully load that ankle and push off and cut and do some things, and taping and bracing might be helpful in those cases, but are you able to do those things, right? But if I see you limping around, then that is a potential risk factor for suffering another injury somewhere else. And that's the type of situation that I would love to really see none of, right?
Yeah.
And so that's something that we want to make sure that we avoid as much as possible, is putting someone out there who is visibly in pain and cannot function to the best of their ability. And that's not only going to compromise their health, but also probably from a performance standpoint, it'll affect the whole team too. So those are moments where the conversation is, listen, like, you're likely gonna hurt something else maybe, and we want to make sure that uh you know we don't do that. We If this is an injury that's serious enough to potentially really affect your function, then we want to make sure that we take care of that the right way. So that's the type of conversation that probably will happen acutely in the first few minutes, once we assess the function and we see that the function is altered.
Yeah, no, I think that's a great point on assessing the function and not just relying on the pain, because everyone's going to report their pain a little bit different. And I know there's a lot of people out there that are doing great work in the pain science space, but I just don't think we have enough of it figured out yet. Give an example. I've seen individuals tear their ACL and they're completely pain free. They're
Hmm.
running, they feel fine, and I've seen other individuals tear their ACL and they can barely walk.
Hmm.
So regardless, it's the same injury. It's still going to limit them in their ability to cut and pivot, whether or not it's, intact or not. However, their pain level after that injury could be drastically different from one
Hmm.
individual to the next. So I
Yeah.
think we can't base that conversation off pain alone. It's interesting to me too. You brought up that you've seen more ankle sprains and ankle injuries in the males than the females. And I think that at this point, a lot of people have, come to the conclusion that we see more ACLs in females than males that way. Any thought as to why you might have seen more ankles in the males than the females, or why you might be seeing more knee injuries in the females than the males that way?
I don't know if I really have a good answer for the ankle question. Um, uh, there might be data, in the research world somewhere, but I can't necessarily tell you, off the top of my head what those numbers are. It might just feel like they are more frequent because we don't see as many ACLs. right? But it's again, it's more of an anecdotal observation comment from me. So, um, but particularly in terms of females and ACL injuries, there's, I think, a lot of interesting factors that may contribute to an increased risk. And, some of that is just the natural makeup of the female body, right? Wider hips, which means the knees will angle down into a little bit more valgus, and they tend to have a little bit more dynamic valgus with movement and function. Does that increase risk? Again, questionable, but definitely potentially. Another thing that I've really, especially working with the women's side now, something that has already caught my attention is the role of the different phases of the menstrual cycle and how that might affect ligamentous injury, or soft tissue injury in general. And I definitely didn't do a lot more research on this, but the initial things that I've seen is different types of hormones. So relaxing, for example, increases ligament laxity, right? And estrogen will decrease collagen synthesis. And so, muscles, tendons, and ligaments, right? They are, particularly ligaments and tendons, they're largely affected by those two things. It just seems like there's definitely a correlation there that needs to be dug into deeper. And I also saw, again, with quick research, that muscle and tendon incidence rates seem to double in certain phases of the menstrual cycle compared to others, right? And that is quite fascinating to me, just because that's a relatively newer area that I'm diving into at the moment, having worked with men's side, and men and boys. I will say that I did work with a lot of youth athletes during my time at Orlando City and Minnesota. That's not something that you see in that male population, obviously,
No.
right? So that's really fascinating. It's piqued my interest. So that's something that I will hopefully go into a little bit more in detail, into that, nerdy research area, So I'll definitely be intentional about taking time to research that a little bit more, so I have a better understanding. Hopefully, talk to some experts as well. Um, and I think I've mentioned that, as well as just the body type, but also nutritional deficits as well. Seems to be a really bigger topic in the female sports circles than on the men's side. Not that nutritional deficits doesn't exist in the men's side, but especially with the different physiological demands that females have, particularly during certain phases of the menstrual cycle, their energy depletion, right, is at a different level than their male counterparts. And so ligamentous injuries, bony injuries, muscle injuries, they might tend to happen, more in female athletes because of that factor as well. So yeah, I think there's a lot to dive into that. We can say, potentially this, potentially that, but as we all know, it's multifactorial in nature. All these injuries, ACLs, hamstrings, whatever it might be. So it's hard to pinpoint what one exact mechanism or reason any particular athlete may injure their ACL, but it's definitely a really interesting topic to dive into.
It really is, and I'm willing to bet that it's never just one thing. I think the majority of the time it's a variety of things. As you mentioned, it's multifactorial in nature, and I think that ultimately we're not doing our job if we don't recognize all of the factors that may be contributing to it, right? Like, if you asked me when I was in school about the endocrine system and its role in musculoskeletal injury, I probably would have laughed at you because,
Hmm.
I'm in grad school at the time. I know
Hmm.
everything, just like everyone else in grad school, right? And then you get out there in the world and you quickly realize, oh, I don't know nearly as much as I thought I did. And, to your point on estrogen impacting collagen synthesis, testosterone also impacts collagen synthesis. However, from my understanding of physiology, males hormonally fluctuate on a 24-hour basis, whereas females roughly, give or take 28-day
Hmm.
basis. So, you have a consistent hormone fluctuation cycle every day for one versus the other being almost, monthly that way. And then obviously there's so many other factors that can impact that, whether you throw hormonal birth control or other things into the picture
Hmm.
that way. But, going back to my comment before about tendons being dumb that way, I can't help but wonder with you saying that there's significantly more likelihood of certain, times of the month that way for soft tissue injuries to occur. I can't help but wonder if that's a point where, the tendon is essentially in a slightly weaker state because it's not getting the collagen that it would need that way. Or, even taking it a step further, like I think type 2 collagen, you might have to correct me on this, is what makes up a lot of the joint cartilage in the body that way. And obviously, cartilage injuries are not the most common thing I ever see in athletes, but it's also one of those things that when I do see them, they're pretty darn devastating. And, it could be something that I think might warrant a little further work, research, discussion that way in the future.
Yeah, I mean, you bring up some really good points there, and again, I'm just fascinated by it, and I'm intend to be a student in this, um, as I deepen my role in what I'm currently doing. So, um, yeah, no, it's all very, very interesting.
100%. And, obviously we were talking before we got on about different like acute response, acute injury situations and scenarios. And obviously there's a lot of courses, and obviously you can go to school and become an athletic trainer to get specialized in that specific thing that way. But in general, when it comes to like that quick crash course, 30-second kind of overview of what are you going to do when one of your athletes goes down with an acute injury of the lower extremity that way? Walk me through kind of like your process and framework that you use, if you will, when one of your athletes does go down with that lower extremity injury. Maybe it's the knee, non-contact knee injury, something like that. What's that kind of like general flow and format look like for you? I know you mentioned the functional assessment earlier, but I'm assuming that's not the first thing that you do with that person.
Yeah, that's correct. Definitely don't jump into the functional stuff first. I think if you can, as an athletic trainer or health practitioner, it doesn't have to be an athletic trainer for sure. There's a lot of high schools and youth teams that don't have any kind of medical coverage, right? And so I think that's really the first step is, having someone that's qualified to be able to provide those assessments right away. Um, Typically, if there aren't anyone, medically qualified to be able to uh, give that quick assessment initially, right? Let's say it's a youth club soccer team, and there's no athletic trainer. The hospital is, an hour away, things like that. It's, that can create a little bit of a dilemma in terms of yeah, your knee hurts. Well, can you go or can you not? And it kind of puts the onus more on the player, maybe the coach, maybe the parents, and that might not bode well if it actually is a serious injury. So I'm just going to start there. The process really is one, I think, as a medical provider, if I can see what the mechanism of injury was, that gives me a lot of context. So if I'm approaching an athlete, I've already seen what happened. It was a acceleration to deceleration with trying to change direction, pivot, react to the opponent, and the foot gets stuck and the body goes one way and the legs stay there. That's a very, very common mechanism for a typical ACL sprain or a ACL injury. If I see that, right, I kind of have an idea right away of that would be my first guess is potential ACL. That would be something that I want to rule out right away. So, first things first, get to the player, the athlete who's injured, and calm them down. That's the number one thing, because if they are screaming in pain and they're not letting you touch the knee and have a proper evaluation, there's really not much you can do. So, getting the athlete to calm down is critical. Get accurate information as much as possible, as quickly as possible. And for that to happen, you need a calm athlete. So that's number one. Secondly, I would say just getting a subjective, what happened? What do you in your own mind recall happening? And getting the athlete's perspective of the injury mechanism. I think that's a really key piece of information as well. Oftentimes with ACLs, you say my knee twisted and I felt a pop, right? And that's a pretty good telltale sign that potentially there's a serious injury involved. And then checking range of motion is one of the things that I would do. But before I do that, excuse me, not to jump the gun, but kind of what I was saying earlier is you want to make sure that there's no bony injuries, right? If there's a severe tenderness across the tibial plateau, it might not necessarily be an ACL injury. It could be a tibial plateau fracture, right? And that type of stuff you don't want to range. You want to make sure that you are stabilizing on the spot. So making sure that those boxes are checked, right? Let's say particularly with adolescents, both men or males or females, you're going to see, there's a percentage that you're going to see of growth plate fractures, right? Salter Harris, distal femur or proximal tibia, and those you don't want to range, right? And so you don't want to just jump right to the conclusion of, okay, potentially it's an ACL. It could be other things as well. So you want to make sure that you palpate the bones. You want to look for any kind of obvious deformities, and those you need to get splinted right away and transported to the hospital. That's a no-brainer.
Yeah, 100%. I just want to throw out there real quick. I love your point on the palpation because when I was going through school, a lot of, the emphasis, in my opinion, was on special tests alone. And obviously, special tests are very important, but I've certainly gotten my fair share of false positive special tests on different things, especially ones that you're looking for, an elicitation of pain response that way. A lot of times there's other things that can cause pain with those maneuvers. And I think that it's really essential to actually dig in there with your hands and see what you can feel and see what, specific prominences are really tender that way. Give an example. I had someone who, had a pretty severe patellar bone bruise on the undersurface of the patella. And I was convinced it was something more meniscal because there was this pseudo instability. There's this, real resistance to knee flexion and knee bending that way. And it ended up being something bony instead of something internal that way. And I just completely, misguided myself because I probably should have palpated a little bit more and spent a little too much time or put a little too much stock in the special tests alone that way. And obviously, if they're positive, you've definitely got to take some kind of course correcting action or follow up step that way. But I find a lot of times I can't put all of my stock in special tests alone. I have to add that palpation filter in there as well.
Yeah, no, for sure. It's a great point, and yeah, I mean, palpation is typically the first thing, as obviously checking for any kind of obvious deformity, excuse me, first. If you see anything that's like, that's not the knee, that's in the thigh and that's bent the wrong way, those are like, I wouldn't even touch them. I would say, all right, let's splint you up and then get you transported. So but kind of getting back into the knee, if all the bony prominences are relatively normal with palpation, then I would probably try to get into the joint line a little bit and see if there's any kind of sensitivity there to palpation. As you know, Dan, oftentimes with ACL injuries, they're associated with some sort of meniscal injuries, medial or lateral, and sometimes potentially with MCL injuries and other ones that are super severe. They may be either involving PCL or LCL. So you definitely want to make sure that you start to figure out what areas are the most sensitive. This could be really tough acutely within the first, several minutes, just because everything is going to be sensitive, especially if there is truly an ACL tear. So, so just kind of poking around, figuring out, really, one, is there any kind of bony sensitivity that we should be concerned about? Um, if not, then the next thing I would do is probably go into the range of motion. Just, hey, how much knee bend can you have, right? Flexion, extension. And if they're severely limited at that point, I'm like, well, if you can't bend your knee all the way, then, there's really very little chance that you're able to function on the field, even if you are able to weight bear. So at that point, it'll be like, all right, let's take you out and take a further look. If palpation, range of motion are all good, then the next thing would be testing strength. So knee extensors, so quads, right, and knee flexors, hamstrings. I would go into calf as well. So plantar flexion to check for any kind of gastroc problems, if there's any kind of posterior tenderness, in the muscles, check for those. And then if all the muscles are good, they can provide some resistance with or without pain. And then the next thing would be to go to the special test, like you said earlier, Dan. First thing I would do is probably check Lockman for ACL. If there's laxity or not a clear end feel, it's I'm not going to say that it's easy to feel, because it's not for everyone. There's a lot of guarding that happens, immediately after injury, and it's really hard to get a read on it. But typically, if there's one that's stable, I would know. Like I've gotten to that point. And if there's just a missing end feel, I always have a question mark behind that. So that would be kind of my on-field assessment as the player is still on the ground, right? If all those things are okay, or let's say I do feel a Lockman that is positive, then I would try to get them off the field safely. And whether that is, if there's a stretcher available, usually for, let's say, youth sports, there isn't. For the professional levels, that those are, mandated to be on the sideline during match situations. But sometimes when it happens at training, then, they need to be helped up and carried off the field. So figure out a safe way to transport the athlete off the field, so that you can take a little bit more time to do a more formal secondary assessment. Now, if all the tests are normal, right, then really the question becomes, okay, can you weight bear and can you take a few steps? And yeah, that's kind of how you would assess, initially assess for function. Can you walk normally without a limp? And if they're able to do that, then you can start ramping it up. So I do apologize. I kind of jumped from place to place, I feel like, but and it's been a little long-winded. But I'll let you have a comment or two here, Dan. I feel like I've been talking too much.
No, I mean, you brought up so many great points and so many big things that way. And just to kind of run it back, obviously we talked about the importance of palpation that way. And I think to your point as well about assessing range of motion and strength, like I know a lot of clinicians that are cutting that out of their assessments, and they're no longer looking at range of motion, or they'll look at it, but we're just going to kind of eyeball it real quick. And obviously, if you're acutely eyeball, it might be the best you can do. But if possible, I really like the goniometer in that piece that way. So, I like to actually see like, hey, how much are we missing? And also, how painful is it? So I find, and this is just, anecdotally that way, but I find if someone has pain with both flexion and full extension of their knee, and they've got some kind of positive special test, like say a McMurray or a Thessley or Apley, or take your pick that way, and they've got palpable tenderness, like that cluster for me is obviously like, hey, look, like we're gonna take some time. after seeing all of those things that way. So I think that combination of assessing everything really helps paint a bigger picture for you that way, as far as what they might have going on. And to your point on special tests as well, obviously when you've got the experience that you have, it's very second nature. But when you're newer or younger, or whatever term you want to throw at it, my biggest recommendation to clinicians is to get as many repetitions of this stuff in as possible on anyone and everyone you can, right? So for myself, I've been practicing about 3 years ish now, and every knee that comes in to see me, assuming they're not post-op, is getting a Lockman, a valgus, and a varus. Whether or not they need it or not, it takes 10 seconds each, if that. It doesn't take that long, and I think it really helps you get an appreciation for how different knees would feel. And I think there's a lot of, value that comes in doing things over and over and over again that way. So I think that your overall response was really well oriented that way. The biggest thing I think for clinicians is just make sure they get their reps in.
What you were mentioning about the special tests, I always compare bilaterally, right?
Mm-hmm.
And so if there is, it would be a little bit different if there's a previous history of, an ACL injury on the other side, let's say, right? That Lockman may be compromised depending on the situation. But if it's a healthy knee, that would give you your baseline, right? And so if you can get a good clean Lockman on one side, but then not on the side that just got injured, right? That kind of gives you an idea of maybe there's something going on here. So so that is something that I always make sure to do, so that you can kind of have a baseline of, all right, what does normal feel like?
Yeah, what does normal feel like? But also to your point that you made about making sure the athlete is comfortable, I think that there's a lot of benefit in the athlete knowing what you're going to do, where you're going to be, and so on that way. So if you, do it on the non-involved or non-injured side first, then they kind of have this kind of expectation, oh, okay, this is what he's going to do, as opposed to, I have no idea what's coming my way.
100%, correct. Especially when it's a first time injury, right? This athlete has never been injured before, and they are, let's say, like, 14 or 15 years old, right? And they're scared. They're scared. So, when you say, "Hey, I'm going to test your good side, and these are the tests that I'm going to do on the other side once I'm done," I think that gives them a good idea of, you know, what you're going to do, and that prepares them, so that hopefully you can get a good test rather than them just guarding the whole time.
100% agree with that. And, to that point on guarding too, I find a lot of the times it's very difficult to get that like read, so to speak, on things when they're guarding up. And I think until you feel it clinically, you won't know what I'm referring to. Or, if you haven't felt it clinically, you don't really appreciate how much someone can guard after an injury that way, because you could be fighting tooth and nail to try and get something. And that's one of the many reasons that, like, I don't really ever do an anterior drawer anymore, because I think that there's too much hamstring guarding that can take place there. And I think that Lockman position, or I also really like the pivot shift a lot. I think those, and the other piece too on the guarding, with the pivot shift, if they're fighting and guarding like crazy, when I get right to that point where I expect there to be a little subluxation, I think that also tells me a lot about the extent of their injury and what might be
Yeah.
going on as well.
Yeah. The apprehension piece, right, to the testing, I think that is telling for sure. Even though you may not be able to actually do a pivot shift, if the athlete's like, no, I can't do this, like that's a good indication that there might be something going on.
100%, 100%. And the other piece too is obviously, like you mentioned, I think a lot of times when people see non-contact knee injury and someone goes down and doesn't get back up, everyone automatically assumes ACL, and obviously we want to rule that out. But as you alluded to, it's not always just ACL. It could be meniscus with ACL or isolated meniscus. It could also be MCL. I remember rehabbing a football player who actually had an isolated MCL sprain, which I thought was kind of odd, but it can happen. I've also
Hmm.
seen more LCL injuries clinically across a variety of different sports lately where, the last 2 years I might have seen one LCL. Now I'm seeing multiple. So it's very different. And I think that while it's good to, rule out the ACL, make sure that you take your time and do your due diligence to actually look at everything else that could be involved, because I think a lot of the times it's easy to miss some of these different things that way, right? It's easy to skip a Varus test because, LCL's rarely injured in soccer, but you never know. You might just have that 1 in a million or whatever number it is case on your hands acutely, and you don't want to miss that. And I think that's another big piece for clinicians is make sure you take your time when these sort of situations arise and get it as close to right as you can. And if you're not 100% sure, hopefully you have a second set of hands, whether that's another AT or another clinician or EMT or something like that around that can actually assess it with you or something like that as well. Because, ultimately, if you're not 100% sure of, the decision that you're making that way, I think that second set really helps inform the athlete of, the righteous intentions, if you will.
Hmm. Just a random thought that crossed my mind as you were talking about MCLs and LCLs, not necessarily from an acute standpoint, but if you're a rehab clinician, with your physical therapist, athletic trainer, whoever, don't keep testing the valgus or varus, right? So if the ligament is healing or is in the process of healing, you don't want to stress that. You want to make sure that you are letting that heal, right? And so, for a good, I would say to be on the safer side, probably like 6 weeks after injury, you don't want to stress the valgus, right? It's just like after ACL surgery, you're not going to do the Lockman. You know what I mean? Like you
Yep.
don't want to stretch that graft out. And so with MCLs and LCLs, if there are isolated injuries, don't keep stressing it. I think that's a key piece that sometimes people forget about.
Yeah, and also taking that a step further, applying it to the rehab for that injury as well, right? Like, if I have someone who's got an ACL injury and maybe we're doing some pre-op work and they keep dropping into valgus,
Mm-hmm.
I'm probably not helping the matter. I'm not saying that valgus is the demon and, valgus should be avoided at all costs, because obviously a lot of athletes are going to end up in that position, but we do know that there is additional stress and strain on certain structures in that position. And
Mm-hmm.
if those structures are already injured, I don't know if I want to add salt to the wound, so to speak, that way. And obviously,
Yep.
from a rehab standpoint as well, the same thing comes true. If there's certain positions that are going to put more stress and strain on injured or surgically operated on tissue, I just want to make sure that I pay respect to the healing of those tissues before we introduce those elements. And again, it's not to say that we're going to avoid them 100% of the time, because athletes never avoid anything 100% of the time. They compensate and move in crazy ways every single time they're, playing their sport that way. But it's just a matter of, is it healed enough, and do we have the other, criteria that I would look for them to be doing that kind of movement.
And you and I are both isometrics people. I think when you have uh, players that are going through movement and they are demonstrating dynamic valgus, maybe stopping them in certain ranges, right, before they drop into valgus, and then working on isometrics in those ranges, right, and creating more stability and better form through through being in those positions in a safe manner. And then as they grow more comfortable and their form improves, then they can start to get a little bit lower into it, or whatever position you want them into, that then hopefully is less of a stressor in that knee. So I think that's a very good use of positional isometrics when you're thinking about that rehab process.
Yeah, 100%. And I think the other big thing that I like about isometrics is I think a lot of the times people think that it's always a horsepower issue and we need more muscle, we need stronger muscle from a like actual physical size, cross-sectional area hypertrophy sense. And I'm not to say that, that could be the case for some. However, I think a lot of the times when I'm working with athletes, I think it's more of like this like underdeveloped neurological system, for lack of a better way to put it, if you will,
Hmm.
where I think that, we actually just have to teach their body how to stabilize in certain positions. And we also need to like kind of like rebuild that connection from the brain to other parts of the body as far as like how they should stabilize, but also like what is a more efficient way to accomplish the task that they're achieving that way. And like I said, athletes compensate in crazy ways, and I think there's a
Yeah.
lot of factors that go into this as well. From a prevention side, but also rehab side. I know you mentioned the maximal stretch position before, and in my
Hmm.
mind, I thought about the rec fem muscle in particular with that hip
Yep.
extension, knee flexion. And that's something that I see a lot with the quad tendon grafts in particular is VMO and rec
Hmm.
fem both really, really struggle to come back after that.
Hmm.
So it's like, obviously we want that in preventative programs, but if someone's rehabbing an ACL and they have a quad graft, that becomes significantly more important. And to your point, I like the isometrics there. There's also some active movement stuff you can do, but I really like the concept of starting with the isometric there, especially in that ACL rehab world. I said before that tendons are dumb. Tendons are really dumb when you take a centimeter of them because they hurt, they swell, and they don't heal as quickly as people think they might. So, starting the process of putting some load through that tendon, getting some kind of remodeling of tissue early on, I think makes a huge difference. And then you also brought up, in addition to the extreme positions, you mentioned reactive elements and deceleration elements that are typically involved with lower extremity injury, whether that be at the knee or other regions that way. And I think
Yep.
that those are also not emphasized enough in a lot of programs that way, right? Like, a lot of times, and I'll pick on the PT industry because I'm a PT myself. How common is it to see the same flow sheet or same protocol with 3 sets of 10 of the same exercises over and
Hmm.
over and over
Hmm.
again? It's like, I personally don't do anything groundbreaking or earth shattering in my rehabs that way. We just kind of manipulate certain variables, if you will. And one of the things I really like on the deceleration piece is the eccentric. We emphasize eccentric super, super heavy in the mid stage of our lower extremity rehabs that way. And I think that there's a ton of benefits that come from that eccentric and isometric combo. And then, obviously, the better you do early on, the more confident athletes are when they work on that reactive element. And I think that that reactive element obviously gets trained a lot in sport, but could also be trained in a lot of different ways from a rehab setting or even in a sports performance like strength and conditioning setting, if you will. I think we just don't quite understand how essential that reactive piece or reactive component can be to athleticism and performance and even injury prevention that way. I think that there's a lot of emphasis on great things, but also, from a carryover standpoint, sports tend to be very reactive in nature, and it's great to be able to, be strong or be fast, but if you can't do it in reaction to a stimulus, then is it going to carry over like you want to the actual like game pitch?
Yeah. For anyone that's interested in the latest and greatest in deceleration research, Dr. Damian Harper is a big name in that space, and yeah, I believe the number is and right, if I'm not right in this, I apologize, but I believe the first step in deceleration can be up to 6 times your body weight, right? And so that is a huge spike in the amount of weight that the body needs to accept. And so if you add in, right, on top of 6 times body weight, the speed and reactivity, and change of direction, I mean, that's just, that's when the injuries happen, right? Is your body just cannot tolerate that load and try to change direction at the same time. So that's an area that I have been really interested in over the past 2 years or so, because there's more research coming out there. Yeah, so Dr. Damian Harper.
Yeah, no, 100%. He's got great stuff on braking performance and
Hmm.
obviously the human braking framework that way. So that's a great resource for people who
Hmm.
want to like learn more about that acute injury, but also that injury rehab side, what other resources or what other educational platforms, if you will, have helped you along the way?
Yeah, particularly in terms of let's say tendinopathy and tendon health. Dr. Jill Cook out of Australia. She's her material has been honestly it's changed the way I look at things and treat things. So that's one. In terms of return to sport progression frameworks, Dr. Matt Tavener out of the UK. Um, his control to chaos continuum framework for sport specific progression after injury. That's one that I always refer back to. There's a lot more research coming out now with visual cognitive dual tasking as well as on-field tasks, and that is one of the newer papers that believe Dr. Tavener has partnered with Dr. I might butcher her last name, Chaput in UCF out of Orlando. Um, so those are some of the things that I've really had interest in as I'm working with in the rehab space for working with elite athletes and trying to provide the best.
Yeah, no, that's great advice, 100%, Mitch. And, obviously those are all great names, and we can obviously link to them in the description below. But I'm sure someone listening is going to want to reach out to you as well. So where can people find you at online, Mitch?
Yeah, my most commonly used social media forum is LinkedIn, and it is under my full name, Michita Toda, Michita, last name Toda. Um, and yeah, just send me a message, please, because I'm usually pretty responsive to that. So
Man, I would have picked you as more of the TikTok kind of guy, Mitch.
I don't do TikTok. I don't have TikTok on my phone. I
Oh
don't
my
understand
goodness.
it.
Oh
I
my
don't
goodness. Well,
understand it.
someday that's going to have to happen, man. Do you have any kind of closing thoughts, closing remarks, or anything we might have missed as we were chatting today?
I'm sure there's other stuff that we can talk about, Dan. There's there's myriad other topics that I'm sure we can do a deep dive into. But no, it's a pleasure talking to you today, and thanks for the time.
Yeah, for sure, Mitch. It's always a pleasure. And to your point, there's definitely a lot more that we could cover. We're really just scratching the surface. So we'll have to do another one of these in the future that way to kind of dig in a little bit deeper on specific things.
Yeah, for sure, for sure.